Before we get started and before I pass it over to Nicole to introduce our speaker, I'd like to pull up a few poll questions. In this chat box, we're going to ask you to please describe the ways that your FLEX program is involved in supporting rural ambulance agencies in your state chosen to report CMS cost data. We'd also like to gauge the knowledge that you know around CMS ground ambulance data collection. So if you could please click if you are familiar all the way up to extremely confident in this knowledge. As you guys continue to type in this chat box, I'm going to turn it over to Nicole Clement, who is going to introduce our speaker for today's presentation. Nicole, I'm going to now turn it over to you.
Sure. Thanks, Kiona. Hi, everyone. This is Nicole Clement from TASC. Most of you know me, but I am a program specialist here at the National Rural Health Resource Center. Thanks for joining us today for our webinar, What FLEX Programs Should Know About CMS Ground Ambulance Data Collection. The purpose of this webinar today is to share with you the reporting requirements for ground ambulance providers and suppliers and what it means to rural ambulance services. We'll share what the implication is for not reporting, and our speaker will also share some resources available to support rural ambulance services in their reporting efforts and share ways that FLEX programs can be involved in supporting them. So with that, our speaker today is Erin Reinert. Erin has become nationally known as a leader, master teacher, and expert in management, leadership, system design, and applied best practices in rural and small-town emergency medical services systems. Erin has been involved in EMS for more than 30 years and is the executive director of an EMS service in central Minnesota. He is well known for asking tough questions and encouraging out-of-the-box thinking. Using such tools as the Balanced Scorecard, Erin has helped organizations recognize the necessary balance between finance, customer service, employee satisfaction, and community awareness. Erin's recognized understanding of current emergency services issues led to him serving on numerous national boards and projects and to an appointment as chairperson of the National EMS Advisory Council by the U.S. Secretary of Transportation. So, Erin, I will turn it over to you.
Well, good morning, good afternoon, everyone. Thank you for the opportunity to chat with you today about cost collection for ambulance service. It's great to see so many of you on the call and many familiar names for folks I've had the honor to work with over the years. As we begin today to talk about this topic of cost collection, you'll notice throughout my talk, one of the things I'm really intending to emphasize is how critically important it is for rural, remote, often volunteer ambulance services to actively participate in this process and to the best of their ability to collect and submit high-quality data. I'm very worried about the consequences of that not happening, and I'll try to connect those dots for you. I also intend to share with you a little bit of the history that got us to the point where the collection of costs is required by CMS, a little bit about how the process will work. It's very involved, and I noticed Scott mentioned in Kentucky they're working with one of the many organizations working on this subject, the American Ambulance Association, which provides an in-depth program to actually teach people how to do it. I don't intend to do that with you today, though I do intend to highlight how the process works and some of the critical components of it, such as how to account for volunteer labor. And then lastly, to really emphasize the leadership role but I think the Offices of Rural Health and the FLEX programs can play, especially with small rural volunteer ambulance services across our nation. My intention, though if you know me, you know I like to talk, my intention is to spend about 45 minutes on the subject, leaving 15 minutes or so at the end to answer questions. That being said, please feel free to ask questions anywhere along the way. The text box is often one of the easiest ways to do that, because I barely pause to take a breath, let alone pause for questions, but I will try to do that as well. So looking forward to you actively participating in our conversation today. So as we begin, this will sound a little bit kind of tomato kind of thing. But this process is about the collection of costs. It is not about cost collection. Now, between all of us, the words mean the same. However, cost collection is a process that is currently defined by CMS, is very highly structured, and many organizations such as hospitals and critical access hospitals regularly collect costs and do cost collection through a cost collection report. And that process has a lot of meaning, has a lot of structure, and that is not the process that ambulances are being asked to participate in. So again, feel free to interchange the words, but you may find someone, especially if they're part of a hospital, a part of a healthcare system, that when they hear cost collection, they're going to immediately think of the cost report that hospitals do. And that is not the report that ambulances will be asked to do, nor does submitting costs that way, which is really part A for CMS, it does not cover the requirement for submitting costs for ambulance services. So while we're splitting hairs, I just wanted to point that process out. This is a unique process developed specifically for ground-based ambulances. And that's the other important point as we begin. This is for ground ambulance services. There is not a requirement for air medical services to participate. It is for ground ambulances, regardless if they do 911, interfacility only, 911 only, some of both, non-emergency, etc. CMS went through and collected MPI numbers, National Provider Indicator numbers, and identified those individuals to report. I'll talk a little bit more about that as we move along. So where did this come from? Well, let's pull back. Prior to 1997, ambulance services had the ability to charge CMS patients that are for Medicare services, and that's what we're really talking about here, is collecting costs and submitting them to Medicare, had the ability to bill a Medicare patient whatever costs they wanted to. In 1997, when Congress passed the Balanced Budget Act, ambulance services were placed onto a fee schedule for Medicare that defined the maximum reimbursement that an ambulance would receive for an ambulance call and created base rates and mileage. There are base rates for basic life support, emergency, non-emergency, advanced life support, emergency, non-emergency, ALS-2, where often you do 2 or more critical or advanced procedures. There is specialized critical transport, often used in interfacility transports, but a number of different base rates, and then there's a mileage rate. Along with the Balanced Budget Act of 1997 and placing ambulances on a fee schedule, ambulance services no longer were able to balance bill. So let's imagine that ambulance sent a $800 bill to a Medicare patient. Medicare might pay with mileage around $400 or $500 So let's say there's 300 left. Prior to the Balanced Budget Act, right or wrong, the ambulance service could bill the patient for the difference. That went away with the Balanced Budget Act in 1997. It's actually against the law. You're only able to bill the patient for their Medicare deductible that they have, a few $100s depending on the area. So about 80% of the reimbursement left the ambulance system when the Balanced Budget Act was phased in fully after the 4-year period, especially in rural, remote areas where often governmental payers, Medicare, Medicaid, are often 70% of that population, and folks with commercial insurances or self-pays are often around 30%. In kind of the suburban, urban, rural overlap, it's often about 50-50, 50% governmental payers, 50% private payers, and often in urban areas, it can be more like 70% commercial insurances, 30% Medicare. Just some rough averages for you. So with that significant change in ambulance reimbursement, we began to see significant shortfalls in ambulance revenue. The American Ambulance Association in 2007 and 2012 asked the Government Accountability Office to actually do a study on ambulance reimbursement. And what they found in 2007, when they looked at data from 2004, is that ambulances were being reimbursed on average 6% below their cost. You can well imagine that that disparity is probably much larger in rural and remote areas where call volume is low, but the costs of operations are high. Often the significant difference there that makes those systems work is when they use volunteer labor, i.e. the ambulance service doesn't completely cover the full cost of labor as if they had full-time staff. So as you can imagine, if this showed in 2007 and again in 2012 that ambulances were under-reimbursed by 6%, that certainly has not gotten better. The price of a gallon of fuel in 2007 is certainly much different than it is today. Interestingly enough, as national organizations have worked to encourage Congress to extend the ambulance extenders, sometimes they're called extenders, bonus payments, add-on payments. That's the additional 2% ambulance services receive on urban zip codes, the additional 3% they receive on rural zip codes, and the additional 22.6% they receive on super rural zip codes. As national organizations have worked with Congress to continue to keep those extenders as part of ambulance reimbursement, Congress in 2012 and 2013, it started in 2012, ended in 2013, Congress asked that MedPAC, which is a bipartisan organization highly regarded by Congress as experts in Medicare reimbursement, Medicare policy, they asked them to do a study of ambulance reimbursement, which they started in 2012 and completed in 2013. Interestingly, the conclusion of that work was that ambulances were receiving enough reimbursement. Now, many of you on this call will likely pause and take some umbrage to that in the services that you're working with, the clinics that you're working with, the hospitals that you're working with, all of those elements of rural health care, that the suggestion that they are not only adequately reimbursed, but MedPAC suggested that they were likely over-reimbursed. Well, where did that come from? So what MedPAC did is they looked at the industry and they saw that there was competition in areas to be the ambulance service. So yes, there are competitions to be the ambulance service in maybe Seattle, maybe Las Vegas, maybe Pinellas County, Florida, Oklahoma City, where EMSA is the EMS authority of, in Alameda County, California, and many other places. However, knowing many of the colleagues that are on this call, Catherine Miller in Wisconsin, there are likely not people competing to be the ambulance service in Ashland. I know there's, folks likely on the call from Wyoming. There's probably not somebody competing to be the ambulance service in Wamsutter, Wyoming, and the list goes on. So they painted with a broad brush. So now Congress was hearing two different voices. One voice saying we're under-reimbursed, another voice saying ambulances are receiving more money than they might necessarily need. So let's also put this a little in context. How much do ambulances get reimbursed? It is state specific. There's a national base rate at each one of these levels, and then those base rates are modified per state. So here they are roughly. These are not exact numbers. Certainly could help you with that if you have that curiosity of how to calculate that for your specific state or an area in your specific state. But using super rural, remember there's rural, urban, rural, and super rural. Super rural has that largest add-on payment, 22.6%. Basic life support is roughly around $500 to $575. Advanced life support is roughly $600 to $625. Mileage about $755. Rural miles, you see them there. So an average ambulance call, depending on how far you might have to transport, might be somewhere around $600 to $700, depending on if it's BLS or ALS. And that may feel like a significant amount of money. But let's see. So if we paused for a moment and actually calculated the true costs of operating ambulance services, accounting for one of their largest subsidies, which is volunteer labor, what we find is it's fairly significant. So just using what a volunteer hour is worth, you can find this out for each of your states. The Bureau of Labor Statistics puts this together. Google the value of a volunteer hour in your state. Happen to have one here from Wyoming in a recent assessment we did up in Johnson County. $24.60 is the number that includes an hourly rate along with wage and benefits and all of those kinds of things. Need two people on the ambulance 24 hours a day, 365, you come to about $430-some thousand. Well, we need some fuel and some supplies and some vehicle maintenance and all of those kinds of things. So there's likely $50 to $70-some thousand for that. So BLS ambulance 24 hours a day, about $500,000. An ALS ambulance, depending on if you're using intermediates, AEMTs, paramedics, and how your staffing may cost between $1 million to 1.2. So 500,000 divided by 128 calls a year says you need to get back about $4,000 per run to break even. But of course, if we're only getting about 30 cents back on the dollar, which is not uncommon, then we need to be charging $6,000-some. Point I wanted to make here was the rates that ambulances receive today are not sufficient. And if rural ambulance services all across our nation are struggling with finding and keeping people and likely going to need to pay more than they pay today, that doesn't mean they're all going full-time. That might mean they're adding a little to be on call. Maybe they're increasing a stipend, adding some training wages. Maybe indeed they're adding some staff for transfers or Monday through Friday or something. That the rates that we receive today from Medicare don't even get close often, especially in rural remote areas. to the true cost of operations. So this process of collecting and submitting our costs is likely the first and certainly the most significant opportunity we will have to show CMS the true cost of operations and hopefully to really begin a thoughtful conversation around what that fee schedule should really look like. So I spent that time to lay that foundation to get us to where we're at today. So most recently, 2018, when the ambulance extenders, the 2, the 3, the 22.6 were set to expire, and national organizations such as the American Ambulance Association, National Association of EMTs, National Rural Health Association, NOSOR, etc., all worked collaboratively to advocate to Congress to extend them. There was a loud voice within Congress, especially within the staff of Congress, that had read the MedPAC report that said, not only should we not extend these extenders, we should likely consider removing some of the reimbursement. So while there was a large push for the extenders, there was a large pushback to not have the extenders. The compromise was to create this system to collect costs, to use data, to use evidence to demonstrate the costs that are really being experienced by ambulance services, and then using those costs, then be able to begin that conversation about what the reimbursement system should look like. So the evidence was needed. Lots of anecdotal kind of stories, but where's really the proof? And the example that I happened to use there from Wyoming could certainly have been from any of the other states simply by using the cost of a volunteer in that particular state. Just happened, Kyle, to have yours handy for some recent work. So the Bipartisan Budget Act of 2018 was the legislation that extended the extenders, but also put in place the cost collection system. So the extenders were pushed out to 2022, and the logic of that was to give enough time for the costs to be collected and for CMS to consider them. So there's some very specific parts of this. CMS was tasked to mandate the collection of costs. In plain English, this means that we'll have this ability to begin a conversation about whether or not the reimbursement is indeed adequate. How will this work? Of all of the, ambulance services in the nation, 1/4 of them will submit their data every year for the next 4 years. So ambulance services that have to submit this year, and lucky me, my ambulance just happened to be picked, so we're going to be submitting by the end of the year. Almost every board member of the American Ambulance Association got picked somehow. But then we will not submit the second year, the third year, or the fourth year. Likely this collection and submission of costs will continue. So if my service has to submit this year, basically for the 2020 calendar year, we won't in 2021, we won't in 2022, we won't in 2023, we'll likely have to submit again back in 2024. So another quarter will submit next year, and so on and so forth. If services choose not to submit, they will receive a 10% penalty on their CMS reimbursement. So if reimbursement was going to be $100, they'll receive $90. So here's one of the things I'm worried about. What if the rural, remote, volunteer ambulance services say, I don't care. That amount doesn't matter to me. Maybe their reimbursement specifically to Medicare is a very small part of their overall reimbursement. What if a majority of their dollars come from a millage, per capita donations, the list goes on. My worry is that the result will be that we'll lose the data from the area where it is the costs are the highest and the needs are the greatest. So that's one of my concerns, is that the penalty, while large, may not be a motivating, a driving force for those ambulance services to collect. That's why I began with the conversation about what are the real costs and what could be in this for not only the ambulance services but the communities and the patients they serve, is to finally have the resources or have more resources that they really need, especially as they begin to understand how they're going to navigate these dangerous waters of how it was to find and keep volunteers 40 years ago to the way it is today. Nicole submitted the current list. There is a link there. The list was published late in 2019. There was one deadline that was already passed, recognizing not everyone uses the calendar year as their fiscal year. Those that were selected were sent a letter by CMS requiring them to report to CMS, I think it was no later than the end of 2019, may have been the first part of 2020, like January, to indicate what fiscal year they were going to use. As many of you know, governmentals often use October, September. There could be the June, July. There's all of those kinds of things. But you needed to disclose to CMS what your fiscal year was going to be. If you did not, they will assume that you're using the calendar year. So you'll be submitting your costs in the early part of 2021 for 2020. That process, CMS is still working out. I'll talk about that here in a little bit. So alluded to this a little bit already. Why is this important? All of us, and especially all of you leading offices of rural health, have been vocal for so long about the large gap between the needs in our rural communities and the available resources to meet those needs. We often talk, and many of you, if I had the chance to talk to you in the orientation that the TAC does for Flex Grant programs, we often talk about the paramedic paradox. So where might we want, from an ambulance perspective, the highest level of care? We would say often in those most remote rural areas. So whether that's paramedics, AEMTs, intermediates, where do we often have them? In the most urban areas. Why? Because that's where the funding of the run volume is. So this might give us that opportunity to actually at least have a conversation about it. We certainly have a strong belief that the current fee schedule and the payment policy doesn't match the particular needs. And we've certainly been suggesting that the cost of readiness, the cost of having an ambulance service in the community, is the real cost compared to the cost that's charged when you go on an ambulance call. So how do we begin to look at what's often called the cost of readiness, and how do we do that without data? And then, of course, there is this belief in some within Congress, in some of the key committees within Congress, that because there's competition in EMS, that EMS must be at least adequately funded, if not overfunded. So we know that in our nation we have, we think, 16-some thousand ambulance services, and certainly there are 20% of the nation's ambulance services that do 80% of the run volume. I noticed Marty Link is on, State EMS Director from South Dakota. So certainly as Marty thinks about Rapid City and Sioux Falls and Pierre, he probably thinks of areas that can support advanced life support and run volume. But as he thinks about Murdo and Jones County, stop on the way between two places. There's certainly no one competing to be the ambulance service for a county that has 1,000 people and 1,000 square miles. The data that's desperately needed, small, rural, frontier, where the costs are often the largest. Ground ambulances represent less than 1% of the total national healthcare expenditures. 85% of EMS agencies in the U.S. bill the Medicare program for less than 2,500 transports a year. 85% of the ambulances billing the Medicare program do less than 2,500 calls. 75% of them do less than 1,000 calls. So if that group of services choose not to submit, we will be missing 3/4 of the true cost of the system. And as I kind of mentioned, it's almost the paramedic paradox in this concept of data. Where we need the data the most is going to be in Murdo County, or Murdo, South Dakota. Jones County is going to be in Johnson County, Wyoming. It's going to be, in Polk County, Wisconsin. It's going to be, the list goes on, where those costs are high because the run volume is low. The worry, as I've alluded to, is that the small rural services, first and foremost, may not know that they were selected. CMS used their national provider numbers, MPIs, and they may have an address on the MPI that is 5 ambulance leaders old. But yet, because typically mail doesn't go to that address, it's maybe the billing agency, is where the claim data goes and comes back to. That letter went, and they didn't even know that it came. They may not have any idea that they were actually selected. Or let's say it's the ambulance service that's owned by the city, but a group of volunteers run it day to day. And so the mail comes to Aaron's house for Aaron's ambulance service, but the legal owner, the MPI, went to the city, and maybe it didn't get to me. They may not care that they were selected. And I don't mean that in a way that's derogatory in any way, shape, or form. I mean as they struggle to operate a small rural volunteer ambulance service every day, to find and keep enough people to go on calls, to be able to go on those long-distance transfers as healthcare has become more and more regionalized, and systems of care understandably expect patients to go to specialty centers. As all of those challenges hit them every single day, a 10% penalty on Medicare calls may not rise to the level of importance to them. To collect these costs may be one more burden in addition to everything else they're asked to do when they volunteered to be the leader of this ambulance service, or they were elected to do the job, or as we sometimes joke, they missed the meeting when they picked the leader of the service. The penalty may not matter. They might not be able to submit the costs because they simply don't know them. Their costs are wrapped up in the fire district or the hospital that owns them, or part of the county's budget or the city's overall budget, or understandably, they're the volunteer. This just gives you a little scatter chart. There are ambulance services in every single state that were collected. Nicole has the link so you can see specifically which ones in your state were selected. So a little of the details. CMS put out their guidance. It's 45-some pages, 13 sections. It is indeed web-based. You see the sections here. I won't go through them in specific with you. This is part of kind of the training that indeed is being done by different groups for folks to go through these and really help them understand. But you can see by these 13 areas, they are in depth. This is not simply grabbing a few line items out of a checkbook or out of a city budget. This is indeed in depth. There are, just you can see these general sections that it has, but also there are costs, and as you submit those costs, you have to understand if your costs are partially or completely covered by the ambulance operations, or you might have costs that are unrelated. For example, let's imagine that our ambulance service is part of the local fire department. And the local fire department, in addition to the ambulance response, does fire responses, but also does maybe some first response and specifically extrication. So those extrication costs are costs that you may have, but are not, in this particular case with Medicare, they would be considered unrelated. You can't include those costs. Yes, we would all say they were absolutely related to that responding on that car crash, but CMS is looking for specifically the costs that are 100% related to that ambulance going on a call, transporting a patient if necessary. Partially might be the firefighter who goes to the scene as a firefighter, but yet jumps into the truck and drives for them because they needed an extra set of hands. So it's part of the fire department which owns the ambulance. In this particular case, there's a partially related cost. And I share that with you not so that I'm giving you enough information so that you could teach somebody else with it. I only share that so you have some breadth of the level of complexity that indeed is going to be asked of ambulance services when they submit.
Hey, Aaron.
Labor costs, please.
Jill Bullock from Arizona had a question in the chat. She was wondering if there was some color coding in that map, if the colors represented something.
Great question.
Go back 2
No. they were only representing that they're the states. So thank you. Great question. Labor costs, I think, are going to be both the area of great confusion as well as the area where the greatest need will be. So as many national organizations worked with CMS to try to help aid them and guide them in the development of this process, there was lots of conversation, as you can imagine, around labor costs, how to account for volunteer labor. So the route that CMS has taken essentially doesn't account for volunteer labor. Here's what I mean by that. They're going to ask people to simply submit their labor costs that they have today. So let's say Aaron's ambulance services volunteer, and we pay people a stipend when they go on a call. So Aaron and Nicole go on an ambulance call today. We take a patient from 2 Harbors down to Duluth, and maybe we get $50 as a stipend to have gone on that. So CMS will say, how many $50 did Aaron get over the year? And then, of course, Nicole and everyone else total that number up, input it in. They will also be asking questions about how much time did people work, so that they, on the backside, will try to reconcile how to really put that into labor costs that look more like full-time. So they'll do a process to try to harmonize between a labor cost that looks like, gee, Aaron's ambulance only cost in labor about $70,000 a year, but yet there were people available 24 hours a day, 365 days a year. So there is some process we're hoping they will use. It's not quite clear yet what it will be. CMS contracted with RAND early on to be kind of an advisor to them in this process, and then they have another contractor that they'll be using to help them go through the data. However, CMS did, I think, a nice kind of webinar question and answer on the subject of labor, specifically knowing that it was such a significant subject. And so that is the link for that, and it'll be in the slides if you choose to download them to be able to share the webinar, watch it yourself, whatever you would find helpful. So what resources might be out there? The one I'm going to talk about today, and there's many, the National Association of EMTs is certainly working on behalf of its members. The International Association of Fire Chiefs and Firefighters are certainly working on behalf of its members. The American Ambulance Association, along with SAVIC, have partnered to provide quite a few free tools for rural ambulance services. The American Ambulance Association is a national organization. Full disclosure, I currently serve as the president for that association. SAVIC, some may know from its former name, it used to be called the North Central EMS Cooperative, actually formed at the kitchen table of Gary Wingroves. For many of you that know Gary, back in 1997, Gary brought 3 ambulance services together in Minnesota. His Healthy's Transportation service I was working for, Wilmer Ambulance Service, to form it. That group has been national for some time. It receives its funding through payments it receives when people purchase at discounts through their buying cooperative. They've partnered with the American Ambulance Association to provide funding to allow ambulance services that do 2,500 or less transports a year to have free access to the tools that the American Ambulance Association has created. Those tools would be available to those services, including something called AMBER, which I'll mention as we begin to close. You can, the services can apply through the American Ambulance Association, and up until here recently, the funds that were available, SAVIC is providing the grant dollars through their foundation to the AAA to provide this service. The grant dollars they had available were initially just for those ambulance services that were picked for this first year, 2020. They've realized and have really, again, been incredibly gracious. They realize that the importance of, even if someone doesn't submit this year, the value of them beginning to get ready to submit. And so they've extended that grant opportunity to any ambulance service, regardless of if they've been selected or not, to be able to participate so that they can begin to become familiar, aware of the process before they actually have to go live with it. They can apply through the American Ambulance Association's website, which is ambulance.org. Just a busy slide that you can see a number of different things that are part of the resources made available through this grant opportunity: newsletters, webinars, a sample chart of accounts, podcasts, access to the experts, the directly asked questions, regional workshops that are put on, and this thing called AMBER. So what is AMBER? We anticipate that CMS will likely have a spreadsheet for folks to enter in their data to submit for costs. We're worried that that process, while fairly streamlined, and indeed that process is done elsewhere for states that are participating in the GEMT Medicaid program, they use a Excel spreadsheet type of tool. The worry is, with 13 some sections and the complexity of those sections, how daunting that spreadsheet would be. So the American Ambulance Association chose to build this program called AMBER. Think an intuitive tool, TurboTax for cost collection, and I'm not plugging TurboTax. I'm sorry, that was the analogy that quickly came to mind. That would ask you questions, lead you through the processes, help you with the calculations, so that you could indeed prepare that the data to submit to CMS. We're hopeful that CMS will allow the AMBER software to directly submit its information directly into AMBER. If it does not, we hope that it will, at a minimum, create the spreadsheet that you will use to submit to CMS. Why I say hopeful is CMS hasn't published that part of the process yet. So AMBER is in place, it's up and running, has been for many months now. Services are actively using it all throughout the year so that when they come to the end of submitting, their data is already in. Services would have the opportunity, if they do 2,500 runs or less through the SAVIC Foundation grant, to have access to not only the AMBER software, but all of the things that come with it free of charge. So that could be a great resource that you may consider. So lastly, in my humble opinion, and no arrogance intended here at all, what might Flex programs do? First and foremost, thank you already for everything that you are already doing. I know many of your programs through the services in your states that I have the opportunity to work with are already doing much of this. First, could you get the word out? Could you identify the list that Nicole has pasted, the link in the box, and touch base with those services to see if they even know that they've been selected? Second, could you help tell the story? Not only could you educate them on the why, so rather than you have to submit, and oh, by the way, if you don't, there's 10%. I don't really care about the 10%. What if we could tell that story? And if I could help any of you in any of your states, I'd be more than happy to do so. To understand the impact this could have if 75 to 80%, 85 some percent of services didn't submit. Again, it's a quarter of that every year. But the value of getting that true cost into CMS. So not only the why, but the what and the how. Connect the services to the resources, whether that's the SAVIC Foundation grant, CMS's resources. They certainly have some that are there. And we just see one that Nicole submitted as well. If possible, this is my humble opinion, might you connect some of the work that you do with their participation in this project? For example, Michigan regularly does a leadership academy, which we are humbled to be able to do with them. Maybe there's a piece that says, and I'm making this up, to participate in the academy, which lots of people like to do and want to do, you need to be currently active in the process of data collection. That could be a stretch too far, might be an example. Communicate, communicate, communicate. This is a daunting process and can feel very scary, which leads me to the last part. Help them bring calm. When a service is doing a few hundred runs a year, there's still 13 sections, but they're not going to be daunting. It won't be as simply as a 1040 easy compared to the 1040 with all of the attachments. It will be more complex than that. But a few hundred runs a year, the biggest challenge there will simply be if they know all of their costs, when many of them are kind of in-kind services. So the more calm you could bring to this process to help them bring that kind of steady hand on the wheel, I think would be invaluable as they move through this process. So that is all that I wanted to present. My contact information here is at the end. I'd be happy to take a stab at any and all questions that folks may have.
So before people start asking questions, and hopefully you guys have questions, I just wanted to say, and just to go back one slide where Erin was talking about communicate, communicate, communicate. Definitely I think it's definitely important to help them know that that survey instrument is out there. You know, I think Erin said it's going to be an online entry system. It's not online yet, so hopefully the tool is representative of what that's going to look like when it does roll out. But I think that there is a lot of value in them having the information now when it's still early in the year, and they can be keeping track of that stuff and actually working on it as the year goes along. I think it's going to be really, really painful for these ambulance services if they get to the end of their reporting period and now they're into their 5-month window for actually having to submit the data, and now they're going back and trying to pull that all together. So communicate, 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 I absolutely agree with. And then connecting program funds, I don't think that is a jump. Erin, what you were saying, I too have kind of had it in my mind that flex programs could maybe be gathering their rurals on a quarterly basis, you know, some kind of cohort to discuss what they're working on, how they're addressing it, and questions that they have. So that's what I was thinking as you were talking about that. I also listened in on one of the CMS webinars. I don't think it was the one you linked, but it was one previously where they really got into a lot of detail about each of those things that people will be reporting and questions they've heard, and people were asking questions. So it feels to me like CMS is doing a great job of communicating about it and answering questions. So those are my comments.
Yeah, I completely agree. And Nicole, something you said triggered a thought in my mind as well. Certainly today we're thinking a lot about those that were selected. Is there a way that we could help encourage those that weren't to begin to engage now? Because
if they weren't selected now, they will be. Exactly. Yep.
Yes. Even beginning to use the chart of accounts, putting the costs in the right buckets, things that they could do now so that when their time comes, whether they're next year or the last year, it'll still be stressful, but maybe less. And I saw a question from Rebecca. So Rebecca, to the best of my knowledge, indeed, in the case of Mercy flights, which is fixed wing, rotor wing, as well as ground, no Tim and Renee and folks pretty well up there, they would be asked to submit their costs with ground. They would also likely fall into some of those partial and unrelated costs, as potentially a flight crew that does rotor wing could also be doing ground, or maybe when rotor wing doesn't fly, they jump in a ground truck. So, but it is specifically for ground and would not be looking to, they will have to select and parse their costs out for those costs that are rotor wing and fixed wing.
Anybody else have questions? Star 2 to unmute your line. Go ahead, Erin, sorry.
Oh, I was going to say the exact same thing.
The other thing I was thinking, too, kind of in addition to kind of what you were saying is, in addition to cohorting possibly these first-year selected rural ambulance services, think about what that group of people will have to teach the second year, the third year, the fourth year, and so on and so forth. You know, share their best practices around what they did to make it less painful and get through it.
Yeah. And I just want to also state the obvious. Those of you that joined a little earlier probably heard Nicole and I chatting a little bit about coronavirus. It's going to be understandably hard to get attention right now. And again, understandably. But CMS isn't going to waive the collection of costs and the submission of costs because of coronavirus. And so I just want to acknowledge that.
Nicole and Erin, this is Jill from Arizona. I have a question.
Please.
Can you hear me?
Go ahead.
Okay. So I know the system in Arizona is AZ Peers, but I don't know if that's the same collection mechanism that CMS wants? How do I find that out, or do I need to go to our Bureau of EMS?
Yeah, I'm not familiar with them specifically, but what I'm assuming, and I use that word very deliberately, so I'm clear about my assumptions here. I'm assuming that's the GEMT kind of program. So indeed, I would encourage you to check in with either the state or the people who, the state EMS office or the Medicaid program, the people who facilitate it. If indeed it's the GEMT program, some of the data and data elements will be similar, but the process will be vastly different. Like Texas, for example, I know they have a state GMT program. They have an Excel spreadsheet that they use to fill out, submit their costs. The process for CMS for cost collection will be nothing similar. Some of the values may be alike, but the collection of the costs and the submission will be much different.
Okay. Thank you.
Scott Helly in Kentucky. I thought I saw you typing. Did you have a question maybe? Star 2 to unmute
I did.
your
So I did. So I just went ahead and unmuted my phone. My question is we have a couple services that was picked that is no longer in service but was purchased out by another service, or they're no longer in business. How would that happen? What would they do then?
Yeah, so again, CMS used the MPI number, so that's extremely common, is that the MPI number no longer exists. The provider went out of service. And so in those particular cases, if they're no longer in business, they're not billing and there's no penalty. We've been trying to communicate with CMS about that. We're worried about the sample and the sample size, that we'll be missing respondents because they actually use the sample. And unfortunately, I'm sorry to bore you with some details here, CMS in the 855 form categorizes ambulances basically in 3 groups. And the biggest group is the others because they don't have not-for-profit, hospital-based, et cetera. So when they created this first quarter, they tried to create a valid sample between the 2 groupings that they have and then the other category. So when we lose a lot because the MPIs aren't valid anymore, we're worried the sample will be off, especially this first year. Now, the ones where someone has purchased the particular provider, it will really be on the people who purchased them to validate whether or not that MPI is still active. If they're using it, if they're using that number to bill CMS, then they're going to have to collect and submit costs. If they purchased, let's say they purchased Aaron's ambulance, and now I'm just part of Nicole, National Ambulance Service, and she has her own MPI number and she bills away, then there's no responsibility there. But people should be double checking so that they clearly understand, are they required to submit, or is that number no longer valid?
Did that answer your question, Scott?
Yeah, that answered it. Thank you.
Sure. Okay. We could take maybe one more question, but before anybody else speaks up, please note that the post-polling questions are up on the screen. I see a lot of people have answered them, but please take a second to answer those 3 questions and read through the upcoming events there. Did anybody else have a question they wanted to ask Erin before we end?
This is Penny from Wisconsin. So going back to the question that was just asked, am I to understand they're not sampling with replacement? So if an MPI number is no longer valid, that reduces the total number of the samples. They're not then looking for a replacement number?
Penny, I always love your questions. I love someone who thinks about data the way you do. So, of course, the answer is no. They're not changing it. So we've been continuing to try to teach them the importance of sample and sample methodology, but I think CMS is fairly inundated in how complex this is. I completely agree with Nicole. The webinars that I participated in have been top-notch. I don't think cost collection was something they wanted to do. It was thrust upon them from Congress. So I think they're doing their best effort. My guess is they'll try to adjust the sample this next year. But even in itself, the sample is off because the categories are governmental, fire, and other. And, of course, there's, all kinds in that other category. It's the tragedy of the null. So the sample as it is going to be as it is.
Okay. Thank you.
We all
Stop
love
using
the way
data.
Penny thinks about data. We all love the way Penny thinks about data, I'm just saying.
I agree.
Okay. Joe had one more question in the chat. When is the reporting due?
Again, the exact time frame hasn't been announced. We're hoping they will share something. There is a window of time. The confusion part comes from, so imagine your fiscal year is January, December. Okay, you would assume there will be a window of time after January 1st, 2021 you'll be required to submit. But what about someone who is starts their fiscal year in July? What will that look like? What about somebody who starts their fiscal year October 1st? So we're still waiting for the very specific guidance on that, though we're being told that there will be a window, so a few months or so that they'll have to get their data in once their fiscal year ends. Nicole, have you heard something different? I know you're watching this very closely too.
The only thing I have heard is just a 5-month window. That's really all I've heard about it, is once